Okay, welcome everyone. This is Cassie Clark with the National Organization of State Offices of Rural Health, and we're excited that you've joined us today for our webinar on a report out on the lessons learned from the Rural Opioid Overdose Reversal Grant Program that you're going to hear a lot more about. I just wanted to go through a few logistical items first before we get started. All lines are muted, so you'll need to ask your questions, which we do encourage. We will have time at the end to answer them, but you'll need to ask those questions in the chat box or in the Q&A box, and I'll monitor those throughout. But we're going to save those to the end, and then we'll answer those as we get to them. And I'm going to go ahead now and turn it over to Mike Blodgett, and he'll introduce our other speakers. Mike is with the Federal Office of Rural Health Policy, and he's a public health analyst. The Federal Office of Rural Health Policy is within the Health Resources and Services Administration, He is the program coordinator for the Rural Opioid Overdose Reversal Grant Program and the Rural Health Opioid Program. Prior to joining HRSA, Michael was a Peace Corps volunteer in Cambodia and an emergency medical technician in Henrico County, Virginia. I hope I said that right, Mike, and I'm going to go ahead and turn it over to you. Thanks for getting us started.
Thanks, Cassie, and good afternoon, everyone. Thanks for joining us. As Cassie mentioned, my name is Mike Blodgett. I'm the program coordinator for the Rural Opioid Overdose Reversal Grant Program here in the Federal Office of Rural Health Policy at HRSA. Before we begin, I'd like to just say thanks to Cassie and everyone at NOSOR for not only hosting today's webinar, but also for doing a lot of the heavy lifting, putting this report together. And also thank you to today's speakers, Melinda Thompson and Ellis for taking the time out of your schedules to join us today. Melinda and Erica will be discussing their projects as well as some of their outcomes, challenges, and lessons learned as participants in the Rural Opioid Overdose Reversal, or the ROAR program. So to start, I'd like to just provide a quick background on what the opioid epidemic looks like in rural these days and how it differs from more urbanized areas across the country. So we know that past year opioid use rates are very similar between rural and urban, and they differ by less than 0.5%. However, death rates due to opioid overdose are about 45% higher in rural areas. So while people are generally using opioids just as often, opioid using populations in rural areas are at a higher risk for dying from an overdose. And one of the primary reasons for this is the long travel distances that must be covered by first responders when responding to an overdose, as well as the limited availability of naloxone in these areas. And to make matters worse, the use of naloxone by EMS is only about 22% higher in rural than urban, which is a substantial discrepancy between naloxone use and the rate of fatal overdoses. We also know that access to treatment is more limited in rural compared to urban. In fact, 60.1% of rural counties lack a physician with a waiver to prescribe buprenorphine in rural counties, compared to only 26.2% of urban counties. So given these statistics, one can really understand why 7 of the top 10 states with the highest opioid-related mortality rates are primarily rural, that being West Virginia, New Hampshire, New Mexico, Ohio, Kentucky, Utah, and Pennsylvania. So in response to these discrepancies, the Federal Office of Rural Health Policy piloted a program in 2015 called the Rural Opioid Overdose Reversal Program. Again, it's the ROAR program that funded 18 awardees to develop community partnerships in an effort to combat the opioid crisis at the local level. The goal of the program was to reduce the incidences of morbidity and mortality related to opioid overdoses in rural communities through the purchase and placement of naloxone, in addition to the training of licensed healthcare professionals, emergency responders, and other community members to recognize the signs and symptoms of overdose and administer naloxone. The partnerships collaborated with local stakeholders to increase the availability and utilization of naloxone in their respective communities, while emphasizing the importance of referring individuals dependent on opioids to an appropriate substance abuse treatment center. So the report we are introducing to you all today is titled The Lessons Learned from Rural Opioid Overdose Reversal Grant Recipients. It provides a summary of the lessons learned from the grant recipients on how to engage, educate, and connect stakeholders to available local resources to help combat the opioid overdose epidemic. The material from this report comes primarily from information submitted to HRSA by grant recipients, as well as from an interactive focus group that was conducted earlier this year for all grant recipients. And the three primary aims of this report are to, 1, document the lessons learned of the ROAR grant recipients in addressing the rural opioid crisis in their service areas, 2, to share the resources for community engagement, outreach and education, and referral and treatment options to help guide other rural organizations considering addressing opioid-related issues within their states and communities, and 3, to generally document the overall impact of the pilot program. So I encourage everyone to take 20 minutes or so and read through this report. Hopefully you'll find something inside that will be useful to you if you choose to develop your own opioid education and naloxone distribution project or any other community-based project focusing on combating the opioid epidemic at the local level. So let's now take a few minutes just to flip through the report so you can see how it's been structured and formatted. So we're going to begin. Page 3 is the introduction. And this provides information on some of the urban-rural discrepancies and includes some of the latest data from our research centers, which are the WWAMI Rural Health Research Center at the University of Washington School of Medicine and also the Maine Rural Health Research Center at the University of Southern Maine. It also includes a description of the ROAR program and a bit more information about the purpose of the report and how it was developed. The grant program data page includes a map of the service areas covered by the grant recipients, as well as a snapshot of the program's outcomes, including the number of trainings and the number of individuals trained, as well as how many naloxone devices were purchased and what kind of devices were purchased. And now we get into more of the lessons learned part of the report. So upon reviewing the reports from grantees and hearing their insights during the focus group, we noticed that grantees often face the same challenges, but they responded to them in different sort of innovative ways. These challenges coalesced around 3 common themes. So building a partnership, providing effective outreach and training, and referring to treatment. So as you can see on this page, we begin with challenge number 1 is building a partnership. And then we go on to describe the common issues amongst grantees in their attempts to build a partnership at the local level. And on the next page, we identified some of the ways grantees overcame these challenges. So for example, you can see law enforcement mentions on the left side under community partnerships included. Many grantees at first did not receive support from their local law enforcement due to liability and stigma concerns primarily, which is noted on the right side. However, they noticed that when they were able to overcome these concerns and law enforcement became willing participants, other community entities were more willing to join the partnership and become involved in the project. You'll also notice that throughout the report, we've highlighted the experiences of specific grantees in these yellow boxes, highlighted grant recipient spotlight. This one, for example, details the experience a grantee from Nevada had in creating meaningful engagement with community partners. Now, I won't go through each specific section, but here you can see that we switched gears a little bit to discuss the challenges of providing effective outreach and training. And we note, see right here, we note 5 key educational themes that grant recipients often discuss that you may find useful in developing a curriculum tied to your community's needs and objectives. The final challenge, referring to treatment, is a challenge nearly all of the grantees experienced in one way or another, especially when attempting to refer someone to treatment while on the scene of an overdose or anywhere really outside of the clinical setting. And this page highlights some of the methods grantees utilize to refer people to treatment, and it's broken into 2 settings, on scene and within a clinical setting. Towards the end of the document, we've included 2 appendices. So Appendix A includes a series of links to a variety of training, data, and outreach resources and materials developed by the federal government, such as the CDC or SAMHSA, as well as other organizations concerned with rural health, the opioid epidemic, and finally from ROAR grant recipients themselves. And Appendix B includes a brief description of each of the 18 ROAR grant recipients. So I encourage you all to reach out to some of these organizations that may be in your area to learn about their success and gather some useful tips and advice for implementing your own overdose education and naloxone distribution project. So, as mentioned earlier, we are fortunate to have two speakers join us today in our webinar. So first, I would like to introduce Melinda Thompson. Melinda is the Grant Program Manager for the Maine General Harm Reduction Program, which consists of overdose prevention programming and the Next Step Needle Exchange located in Augusta, Maine. She's been with Maine General since 2014. I'm also pleased to introduce Erica Ellis Bartling. Erica is a crisis counselor, director of Camp Mariposa, West Virginia, and program director for Project Renew West Virginia through Community Connections Incorporated. She has 3 Bachelor's of Science degrees with focuses in psychology, crisis counseling, and substance abuse and recovery, and is currently finishing a Master's of Arts degree in professional counseling through Liberty University. Prior to joining Community Connections, Erica was a child advocate and mental health professional who served in rural communities in Virginia and West Virginia. So thanks again to our 2 speakers, and at this time, I'd like to turn the presentation over to Melinda.
Can you hear me? So I'll just get started, and Michael, stop me if you can't hear me.
We can hear you.
Okay. And just to give kind of a background about Maine General is a hospital system located in central Maine that's really part of a larger provider hospital organization, a PHO, and that includes a number of private practices and also federally qualified health centers. And we serve primarily Kennebec and Somerset counties in Maine, which is a rural area and kind of more so as you continue up toward the Canadian border. But as was kind of mentioned in the introduction, the harm reduction program is really integrated because we offer a number of services, including our needle exchange program, HIV and hepatitis C testing, and education on overdose prevention and naloxone. And we're within kind of the population health division of our hospital, and we do a lot of other community-based education as well. And back in 2014, we were fortunate enough to get money from the Attorney General in Maine to do a pilot program called this Emergency Opiate Overdose Kit Project. And that's when really we started this naloxone work. But ROAR was a good fit for us because we already had a lot of good experience doing this Emergency Opiate Overdose Kit project. And as such, we had a lot of good buy-in from medical leadership and law enforcement, but also because the data, as you can see, really shows us that the trend of drug-related deaths in Maine is increasing dramatically. In 2015, there was this switch. You can see total is in blue, pharmaceutical-related, and illicit in the trends for those. In 2015, it's that kind of switch. You can see where more drug-induced deaths were related to non-pharmaceutical. That's in our area, heroin and fentanyl, versus pharmaceutical opioids that are used for medically chronic pain and pain control management. And last year alone in Maine, there were 378 overdose deaths. Kennebec County, the area that Maine General serves, has one of the highest number of deaths compared to other counties in Maine, so we really felt like this was a good fit for us. And what Maine General focused on, as I kind of mentioned before, the ROAR project allowed us to expand and strengthen the naloxone work that we had started. And we focused on these 3 things: training law enforcement to carry and administer naloxone in emergency settings, also expanding community education about overdose prevention, risk response, and including how to access and use naloxone. And then also our largest focus, I would say, is the training of healthcare professionals and medical staff on naloxone and distributing naloxone in these clinical settings. But with this presentation today, what I would like to focus on most is how this referral to treatment challenge was common and important in all three of these large areas that we focused on, and talk about the lessons learned specifically to our referral to treatment activities. So in the booklet, you can see that there's kind of two ways to refer people. That's on scene and in clinical settings. And some of the work that we first did with on scene referrals, probably like many of you, we had a number of partners from doing outreach and education, and we also had quite an extensive listing of substance abuse resources locally, including treatment, counseling, behavioral health, a lot of other social service agencies, and we also try to always include any peer recovery partners and support groups that we have locally, so that people can have many options when they're ready to be referred or to engage in one of these programs. But as a result of these good relationships that we had, some first responders had actually reached out to us requesting that we revise our substance use resource listing into more of this kind of usable business wallet card to give patients at the scene of an overdose. So Maine doesn't have laws that require patients to be transferred after an overdose reversal, and they were finding that some patients would actually decline further treatment, and it's kind of this missed opportunity. So what we did was we made the wallet cards pictured here. You can see that it talks about how naloxone works and why we encourage you to still seek medical care. But then if you, ultimately, if you choose not to, we still want to help and provide these resources. And so that was a good way to encourage referring people on scene. I would say one of the lessons learned from this activity was that as we were going to distribute these wallet cards to first responders to then give out to their patients, we heard that there might be a want for some sort of support or resource, almost like when and how and where to give out these cards. So what we did was we developed talking points and almost like scripting to help the first responders know how and when to give out the cards. And I think that the feedback that we heard was that these are very helpful, not just because this is a brand new resource and material for a lot of these staff, but also because a lot of these first responders are just now stepping into this work. So it's really important to provide as much support to those new staff and resources as you can, even just like these talking points that we developed and scripting examples. While we might think that first responders and even those trained in naloxone use are knowledgeable about all of this work, sometimes there's a lack in the language, and that this kind of resource and support is really helpful to a lot of people. And then, and I mentioned we focused a lot at Maine General on clinical settings, medical trainings, and referral in clinical settings, naloxone distribution in clinical settings, and that's it worked well for us. We sort of already had the foot in the door being within the hospital system, but it was still a new training for a lot of the medical staff that we were working with. So these are kind of the big lessons learned for us in working with healthcare professionals. So first, we used a lot when we could of data to set the stage, and real data when we could for presenting to medical staff. So in our case, we had been tracking emergency department admissions data related to drug overdose and drug-related admission data. We've been tracking that for years, and so we used this when we were talking with medical staff to demonstrate the need and why we have this ROAR project and why it's important. But what we also did is to get more on the practice level is we worked with one of our IT's report writers to develop this EHR report that pulled electronic health data within our hospital system. The criteria that we used are MME, so daily morphine equivalents, and that's a good indicator if someone has high MMEs it's a good indicator of overdose risk. If someone's on a lot of opioid medications for chronic pain or just in general a lot of different mixing. So what we did is we pulled those reports for each practice that we were about to go present at. So before we went into the practice, we would pull the report, and that helped providers be able to identify which of their patients are on high opioid medications and who could benefit from either a naloxone kit or just more brief intervention or referral to treatment or any of that. And that was, I think practices found that very useful for them. Another helpful piece is when we could, is to use existing workflows and protocols to strengthen the already existing systems or create new systems, especially around the screening for overdose risk, linking to services or prescribing naloxone. And when possible, we tried to make these automated. So again, we worked with our IT department to create an automatic prompt, which for every patient identified to benefit from a naloxone kit in the emergency department, whether or not they come in to the emergency department from an overdose or if they're just identified as being high risk. So an automatic prompt to our harm reduction program would be created. And so every patient that was identified would get this prompt to a referral to us. And the good thing about that is that whether or not they received a naloxone kit, they could get more education from us. We could also reteach how to use naloxone, and we could provide more referral to treatment if that's something that the patient had been thinking about. And so that automatic prompt was really useful so that it was just automatic, one less click for medical staff to do in their busy workflow. And lastly, I would say that we really took advantage of our medical staff trainings, and we didn't just include naloxone education or prescribing information. We also included the SBIRT model, which SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. It's a model of identifying patients quickly to then determine if a brief intervention is needed and whether a referral to treatment is needed. It's not always needed, but the screening piece is really important. And so when we were in the practices doing naloxone trainings, we also spent time talking about how to use screening guidelines or what sort of resources are available in the practice to identify patients. And on the next slide in a minute, you'll see that we developed this list of guidelines for screening someone for overdose risk. Of course, the trainings also did include the layperson education for using naloxone, how to prescribe naloxone and where to access, which local pharmacies carry, which insurances cover, that sort of thing. But then the second bullet is waiver training. More recently, in an effort to, on the other side of referring to treatment, to build capacity for treatment itself, especially in primary care, we've been starting to coordinate waiver trainings that allow medical staff to prescribe Suboxone with the idea that hopefully we can build that capacity for medicated assisted treatment more in the practices. But what's related to this is our lesson learned is it's really important to not just provide the training, but to also, again, provide the resources to then implement this new education. And so what we're doing is we're involving champions to not just sort of make the case of how important this work is, but we're also involving champions who are experienced in the field of addiction medicine. We have a provider who's been providing medicated assisted treatment for years now. She is doing this sort of peer mentoring and support that for providers who are newly trained and just received their waivers to learn from her how to implement that in their practice. And so these medical staff trainings are really more than just the training themselves. We found that it's really helpful to involve champions to provide the support of starting this new work in their practice. And I would just say, and so this, the map shows the Augusta area and the Waterville area, which are Maine General's primary service areas. This map kind of shows that, although, as I mentioned, we expand to Kennebec and Somerset counties as well, which is much larger than this snapshot. But these clusters are where we did the trainings themselves. They're where we have primary care practices. And we started with these Maine General practices because we had the strongest connections there. We hope to expand now to the other practices within our provider hospital organization, like the private practices, like the federally qualified health centers, and eventually, hopefully, to other health systems as well that's in our area. But these clusters are where we started the work. And these are the guidelines. It's sort of a long list, but it's also in that report that Michael was talking about earlier. And this list we developed with this team of not just health educators on our ROAR project, but also pharmacists and medical staff, and it's really based on the literature and also using a harm reduction approach at identifying people who would benefit from naloxone. And you can see the last one is if a patient asks for a kit, because in Maine, while a prescription is required, there's no really limit to getting a prescription. It's just kind of that fact that the prescription is required. And so just quickly, the big takeaways I would say are that our trainings, we really expanded to not just be strictly how to use naloxone. For example, we included those talking points with the first responders to help with language and communication, and we included more of the screening, brief intervention and referral to treatment, and also the waiver trainings and the support from experienced providers as well for medical and healthcare professionals. And we're really working now to even expand that even more, to build more support for the practices and helping them learn these new workflows. And then, again, using systems when you can, like IT reporting, electronic health record reporting to identify people proactively, using automated referrals when possible, when it makes sense, and also using data to get more medical staff on board. It brings it locally. And then lastly, just involve the key partners in the community. And I mentioned when we can, always trying to involve the recovery community themselves, the peer recovery coaches, and then the champions in the medical setting who can help, again, with the support, but also kind of getting this out. And those, I would say, are our largest takeaways. And we can share any of these, especially the guidelines, because I know it's kind of a long list. And any of these other resources we're happy to share as well. And the only other thing I would say is if other healthcare organizations are looking for more information on the waiver trainings themselves, we work with it's AAAP, the American Academy of Addiction Psychiatry. Yes, that's right, American Academy of Addiction Psychiatry. They have a really good buprenorphine waiver training program, both online and what we're doing with the medical staff themselves. So I would encourage people to look at that. But with that, I think I'm happy to answer more questions. And I will turn it over to Erica.
Okay, thank you, Melinda. So our project was a little bit different because we are a very small nonprofit in the state of West Virginia. And I just want to quickly say thank you to Michael and Cassie for their work on this and inviting us to come speak for you guys, because we always like to share about our project and what we've learned so far. But just to tell you a little bit about our project, again, we are an initiative of Community Connections. It's called Project Renew. And the reason why we named it Project Renew is because renew means to restore. And that was kind of a two-part thing that we wanted to incorporate. The very first one would be, obviously, you know, we renew life when we give Narcan, so it's kind of play on words with that. But also to focus on law enforcement and to renew the rapport between law enforcement and the community, because in our area that was certainly lost, especially between addicted populations and law enforcement. So that's kind of why we named the project Project Renew. Again, my name is Ellis. I am the program director of Project Renew, and I put my information on here because there is so much that I could talk about with this program, and so many challenges that we expected, and then also those that we did not foresee. And honestly, I could probably talk for hours on what we learned through this project. So if anyone would ever want to reach out or talk any more about the resources and stuff that we put out, feel free to contact me, and I'll post this again at the end of the slide. But what I'm going to talk about today is primarily the HRSA grant and the reason why we applied and the need that was there. And then we're going to have a primary focus on partnerships and why we partnered with who we did, and what that did to kind of boost what we were doing. And then also, how did we approach referral in a layperson way? Because we are not, you know, a medical system, you know, we're not an addiction treatment program or anything like that. So how did we broach referral in the capacity that we had? So our primary focus for the grant was law enforcement and first responders. And, you know, we wanted to give them training as well as a product to use. And then also we focused on nursing education primarily, although in our area, all the way down from doctors to, I mean, our doctors were refusing to write Narcan, and then to pharmacies who were refusing to fill it if we could get a prescription written. So we had a lot of huge obstacles starting out. And then, of course, layperson certification and Narcan distribution for them to make them feel safe enough to use the product on their loved ones should it come down to that point. So the reason we applied is because at the time West Virginia led the nation in accidental overdose deaths. I believe that current stats say otherwise at this point. I think Ohio is #1, but at the time West Virginia was. Our 3 primary focus counties was in the southeast West Virginia, which would be Mercer, McDowell, and Wyoming counties. And they were all ranked in the top 6 out of the 55 counties across the state. McDowell County was the #1 county in the state, and they are like our neighbors. Community Connections is located in Mercer County. So their overdose rates were actually 13 times the national average, which is higher than that now, but at the time, that's what it was. So if you see here, this is more current stats, but if you see the black brackets there at the bottom, that is primarily the heart of where we're located. The 2 darkest counties there are McDowell and Wyoming County, and of course you see there that they have the highest overdose death rate per 100,000 people. And then to the right there, to the bottom right, is actually Mercer County, where Community Connections is located. So it kind of just made sense that we apply for the grant here. It was out of our realm. It's something that we had never focused on before. It's more of an intervention type grant, and we are huge on prevention. So, you know, it was kind of daunting at first, but I think we did really well in the program. So now I'm going to talk about partnerships really quickly, but I think the most significant partnership that we had was with the West Virginia Department of Justice. We would not have even applied for the grant had it not been for U.S. State's Attorney of the Southern District, Booth Goodwin. He actually reached out to the agency before I was even brought on board and asked us to apply for the grant because, you know, it was needed in the area, and he had other initiatives that he was focusing on, and, you know, just really wanted us involved because he was familiar with our prevention work, and that we did. So when we looked and we started going out and we started talking to law enforcement, especially locally, beginning in Mercer County, we found that we would receive a lot of kickback. The state police did not want to have anything to do with it. There was a lot of stigma associated with the populations. You know, we've even had one look at me directly and say, I'd rather spray the Narcan in the air first and pretend that I saved this guy. They, you know, a lot of military vets and a lot of career police forces here that just didn't want anything to do with the program. So the two questions we asked ourselves when starting off, and you know, this briefly touches on a challenge, is one, how can we get them on board, and two, how can we push other people to become, you know, come on board with them? What can I give them? What can I do here at the agency that would get them on board with this? So we reached back out to the Department of Justice and we said, listen guys, we need help. We need a push to get these guys on board because they don't even want to sit down and talk about it. So what happened is Booth Goodwin, who was again the U.S. State's Attorney at the time, had a media event, which is the picture there on the left, and he was pushing the 1844 Help for West Virginia treatment number, and said, you know, we're going to partner, the West Virginia State Police are going to partner with this nonprofit, and this is an initiative that we're going to stand by. And I think that was the most significant partnership through everything that we had, because it got the ball rolling on getting us into law enforcement offices. So here on the right, I will go ahead and jump ahead and say here on the right, we did finally get in there, and I'm not going to say or pretend that it was easy whatsoever, because it was not. But we did get in there, and our Princeton detachment, which is here in Mercer County, got our first save. And we did receive awards from the then U.S. State's Attorney, Carol Castor, and we got the Outstanding Community Police Partnership, and of course they've got an award for their efforts in saving lives that year. What this partnership did for us was ensure that local law enforcement would follow suit with implementing the training, and I think that was a primary focus for us. So we got into the West Virginia State Police, and then the Sheriff's Department wanted to follow suit, and then City Police wanted to follow suit as well. And then the other thing we asked ourselves is, what can we give them? So what initiative do we have? So not only did they receive free training and free product, including kits, but they also received certification. And I'll talk a little bit more about that later. So step one for us was to become certified naloxone trainers, and that was primarily me. We did not have a team working on this. It was me and then our executive director and our assistant director. So I became certified as a naloxone trainer, thankfully through the West Virginia Office of Emergency Services and the Cabell Huntington Health Department. If you guys have probably heard about Cabell Huntington. They were in the news all over the world last year with their overdose deaths in one day due to fentanyl. So I became a trainer of trainers and then also a certifier. So what that does, and it's an initiative through our laws and our Good Samaritan law, is that if you have this certification, your name and everything goes on a list at our state capitol in Charleston, West Virginia. And should someone decide to sue, that they could pull up that certification and say, well, we know that they were certified and they're covered. So it kind of gave everyone an extra protection, and I think that really helped us a lot with the police officers as well. They were concerned about liability, and that kind of helped us with that concern. And then the second thing was, I was very bold in telling them that this is something that, the whole country is getting on board with. This is an epidemic of, substantial proportions, and, it's an initiative that we need to do, and we were asking officers to go beyond their scope, and to overlook what their typical training was and to add on yet another thing that they had to do. which was a challenge for them because, you know, they do a lot already. So what that did for them is I told them, make sure you put that on your resume because that's going to follow you anywhere you go and that you're certified. So that helped us out a lot with them as well. And it gave them that initiative to come on board with us and to actually get the certification, because a lot of them did not want to be certified because they wanted to have the choice whether to use the product or not. So all of our guys did become certified with the state. The next partnership that I think was significant was with Bluefield State College, and they are also located in Mercer County and also Raleigh County, which is north from us. And we basically went in and was added to the nursing curriculum for RN students, and I personally trained and certified 200 plus new registered nursing graduates on not only overdose reversal, but primarily the importance of patient teaching and treatment referral. And that's so, because with patient teaching, you know, in the nursing background, I'm sure Melinda can probably talk about this a little bit better than I can. But, you know, it's very important that the nurses are catching if any patient is prescribed an opiate. And, you know, that there's other populations other than people with substance use disorders, but anyone that goes home with an opioid prescription should have an naloxone prescription with them because, you know, you guys know the risks. And then also with that partnership, we had an overdose protocol written so that, you know, they knew how to address overdose if it should happen on campus. So that was pretty awesome. And then kind of a byproduct or an indirect result of our grant was to revamp our local coalition. And we do have a good, strong running Mercer County Substance Abuse Prevention Coalition. And then the pictures here you see are an event that we had on August 31st, 2016 for Overdose Awareness Day. And we did do a balloon release. And I do just want to point out that we were told that, you know, these were safe balloons and, you know, wouldn't be bad for the environment, although we will not ever do another balloon release because we got a lot of kickback on that. However, it was a very therapeutic process for the community. Everyone came, you know, we had the nursing students there, we had law enforcement there, and then every single treatment facility within, you know, a 5 or 6 county area in different regions came down, and so the community could walk around and learn about different resources that were available to them in the community, which I think is, you know, a strong factor for the community. They're not aware of what resources are available. So that's why we had that event, and we had special speakers, and it was a phenomenal event. So that was a partnership and a long-standing partnership that will continue with the coalition locally, and they'll continue the work that we started through this project. The last partnership I want to talk about is the West Virginia Bureau of Behavioral Health and Health Facilities. Of course, that is the federally designated state authority for mental health and substance abuse in West Virginia, and they do implement planning and training and funding for prevention and treatment and recovery services. But they had an initiative called the 144 Help for West Virginia number, and it was coming out about the same time that we received funding through HRSA. So we were told that if we pushed that initiative, that anytime someone would call the 1844 Help for West Virginia number, that they would be ensured that there would be a bed made available to them somewhere that they could go to for treatment. So that was huge. And then also we had a wallet card similar to what Melinda was talking about. And, you know, that stayed with everyone. And I'm sorry, guys, about the phone. But that stayed with everyone, and any law enforcement, any kit that was going out, any, you know, fire and rescue, any of those, they had those cards, and we gave those out to families and let them know if, you know, in that small window once that they were revived, if they decided to seek recovery, that they would have a bed available should they call that number. So I think that was the primary way of referring for us. Also, the next one would be the Are You at Risk overdose cards. These cards were distributed in the community at all events. They went into doctor's offices, they went into pharmacies, and basically, an example there on the right, it talks about what opioids are, what overdose is, and how it happens, and then of course what naloxone is, and then information at the bottom for our agency, and then on the back side is actually a checklist that they would do, and if you answer yes to any of those questions, then you could potentially be at risk for overdose. And what that did is it increased the awareness that this is not just a substance use or abuse problem. This could be anyone. Our rates for accidental overdose were extremely high because of the health factors in West Virginia. A lot of people are sick, and then of course a lot of people have black lung from the coal communities. So, that was a big factor for us. So once they got those, I know I had people walk up to me and say, wow, I'm on an opiate, but I take it how my doctor tells me to, and, I don't think I have a problem, but I do have asthma, and, sometimes I get sick. So I should probably have naloxone in my house. And I'd be like, yeah, you should have that. So it got a lot of conversation started, so that was a really good piece. And then, of course, the 844 Help for West Virginia number was always on the bottom. For any, substance abuse treatment or mental health treatment. They could call that number. So that's primarily how we handled referral for our area. Again, I could talk for hours about all the challenges that we had in rural communities. I think it's probably pretty clear on the challenges that you would have in a rural community, especially if you understand the culture there and the stigma associated with it. So again, I don't want to take up a lot of time, but if you ever have any questions, feel free to reach out to us. We have a lot of resources and a lot of personal stories that we can tell you that, improved our chances in our community. So with that, I will turn that back over to either Michael or Cassie.
So we thank you, everyone. Great job to all of our presenters. Please go ahead and ask any questions that you may have in the chat box. There was one question that we did receive, and I'll go ahead and post that up there for everybody to see. But the question is there a cost? Are there any program funding limits and grant opportunities? So I guess I'll go ahead and turn that over to Mike to take the first stab at answering that question.
Sure, thanks, Cassie. So the ROAR program specifically, it was a $1.8 million investment by HRSA to fund 18 grantees for a single year. So all this work was done in 1 year for $100,000 per grantee. So that would be the funding limit. As for other grant opportunities, we are not going to be repeating ROAR in FY 2017. However, we do have a new pilot grant program focused on opioid treatment and recovery services. It's called the Rural Health Opioid Program, and it's currently it's actually active on grants.gov, so it's posted on June 15th. Applications are due July 21st, so we encourage everyone to check that out. So like I said, it's different from ROAR, primarily because it's a multi-year program, so it's 3 years long instead of 1, and there's also going to be $3 million available for up to 12 grantees. So, if you do the math, it's up to $250,000 per year for 3 years for grant recipients. And this new program, the Rural Health Opioid Program, we're calling it RHOP. It's not focused on naloxone distribution. It's more focused on increasing access to treatment and sort of access to recovery services as well. So, like I said, it's on grants.gov right now. We encourage everyone to go and check it out. We will have a technical assistance webinar for this program on July 13th. You can find more information on that in the notice of funding opportunity on grants.gov. And if you have any specific questions, you can contact me or even your state office of rural health or NOSOR.
Okay, Okay, great. Thanks, Mike. I don't see any other questions yet. I just wanted to remind everybody that I put up the information where you can find the slides that were presented today, along with a recording link. So make sure you go to the NoSOR website to access that. I'll try to find that link to that funding announcement too, to pop that up here real quickly as well. And then I did see a question pop up in the Q&A box. Let me get down to it. I'm not sure if anybody else can see that, but has there been a movement in the states that received the funding and implemented the program to limit how many times a patient could be revived? Recently in Kentucky, I have seen some discussion around limiting repeat EMS calls for overdose incidents. I'll just open that up to the panel, whoever wants to jump into that.
Erica here. There has not, that I know of, been any movement in the state of West Virginia. However, there has been in Ohio. I was just talking to someone about that this morning, and they're wanting to do like a 3-strike rule, and that is, you know, that's out there in articles that you can read. But as of now, in the state of West Virginia, there has not been that issue arise. But I will say that in Ohio, they're wanting to put a DNR on people. You know, the first strike is, you know, the first save. The second strike would be if you don't go to recovery, then they will not come out a third time. So that's what they're talking about in Ohio that I know of.
Thanks, Erica. Any other questions for our speakers? Let's see. I loved the bear at the end of the first presentation in the recovery position. Is that trademarked? That's for you, Melinda.
You know, that was actually developed years ago when we had sort of started this work, but I can look at that and share. I'll check with our marketing department at the hospital. It would be an easy question to ask.
Okay, thanks, Melinda. If anyone has any questions afterwards and can't remember our presenter's contact information, you're welcome to contact Cassie Clark, and my information was on the flyer that was distributed, and I can connect you as well. We have another question in the Q&A box. Hold on. Is naloxone available in local pharmacies in your states?
I can answer for Maine first. It varies. So while it's available, while it is legally available with prescription in Maine, not all pharmacies carry on stock. So what we actually did is to try to make it easier both for patients filling and also for medical providers writing the scripts, we called a lot of our local pharmacies and kept a tracking sheet of not just whether they have on stock, whether they can order it also, and which type of naloxone. We're finding that more are leaning towards the newer Narcan, I think because of the ease of using it, but many still carry other versions as well.
Erica here. In West Virginia, we did make that over-the-counter a little bit after our grant program ran out. So I would say a little bit last year they did make it over-the-counter in the state. However, in our local area, we have one mom-and-pop type pharmacy that has the new Adapt Pharma Narcan on hand, and then they can get the other, but it's quite expensive. And then also the larger chain pharmacies are still working on what I'm told is, you know, how they're going to handle over the counter. So Walgreens and like Kroger pharmacies that have started this in other states are still working on the protocol for West Virginia, but it will be available there as well. And then I can tell you that the Walmart pharmacy in our area is refusing to carry Narcan, but it is over the counter now in the state of West Virginia.
I also want to mention there's a resource in the Appendix A It's from the Network for Public Health Law, and it's a document that has naloxone access laws as well as Good Samaritan laws by state. I believe in that document it'll say what the laws are per state, depending on where you can get naloxone, including if pharmacies are statewide allowed to carry them or should be carrying them, or maybe standing orders need to be implemented or something like that.
And I missed a question from Lynn. It said, name the 7 states once again that were mentioned earlier.
So those 7 states are the 7 states that are primarily rural that are in the top 10 for highest rates of opioid mortality. And this data is from the CDC. And that's West Virginia, New Hampshire, New Mexico, Ohio, Kentucky, Utah, and Pennsylvania. The other 3 states, I believe, were Massachusetts, Rhode Island, and I'm blanking on the third, but you can just Google and it's from the latest, I believe it's from the latest MMWR report from the CDC.
Thanks, Mike. I did post in the chat box the link to the RHOP grant opportunity that Mike mentioned earlier. And there's one other question that I'm going to populate in the chat box as well. How involved did partners get to advocate within state boards of pharmacy or medicine, nursing within their initiatives?
I'll say that this is Melinda. We weren't too involved with state boards. What we did contact them about things like with the Board of Nursing, the changes in nurses and NPs and PAs becoming eligible to apply for their waiver to prescribe Suboxone, that sort of thing, was helpful for us when talking with our own leaders within Maine General, the healthcare system. We have discussed possibly using the trainings that we did with the emergency department, sharing that with our pharmacy board, just because right now Maine is trying to get naloxone to go over the counter, but it depends on the training that the pharmacist gets. But so far we haven't done that yet. But I think it's a good route to go.
Erica, do you also want to answer that, or I can move on to the next question?
Primarily with the Board of Pharmacy in the state of West Virginia, they already had their own initiatives, and of course we advocated with them with that. And then I can say that our nursing students who were involved with different things in the state advocated for over-the-counter, and that's quote-unquote over-the-counter. I think our biggest problem at this point is the cost point and, the training involved. So we did talk to, law creators and the Board of Pharmacy as well on how they can do over-the-counter. And so I think they implemented like a 30-minute training that their pharmacists have to do. So there was advocacy there, but our agency alone did not do that, but our partners did.
And one thing, can you hear me?
Yes.
That makes me think also, well, not at the board, but when we did medical or health professional trainings within our health system, we included a competency at the end, which I know, at least in the emergency department, they really wanted that competency to go into the nursing staff files as part of their ongoing training. So that's another idea.
Great. And then one last question, Mike. I made you presenter again. If you wouldn't mind flipping to the part of the report that you just mentioned for that, I guess it was a link to the, I felt like it was a Good Samaritan report, but just to point out that all of these, so this report is on the NoSOR website. which is the link that I did provide earlier. And you can find all these links here. There's also some additional resources that are posted on our website as well. But if you have any problems accessing any of the information mentioned, please feel free to reach out to me, and I'd be happy to send it to you directly.
Yep, and the one I just mentioned, Cassie, is this one, second from the bottom on the right side. It says legal interventions to reduce overdose mortality, naloxone access, and overdose Good Samaritan laws.
Thank you. And at the time, I feel that that's all the questions. I'm just scanning through to make sure. Yep, making sure I didn't miss any. And we appreciate the Federal Office of Rural Health Policy's initiative on this, and it's been a pleasure working with you. And we also want to thank Erica and Melinda for presenting today as well. It's great information, and I hope everyone got a lot out of it. And with seeing no further questions, I'll conclude our webinar for today. Thank you for joining us, and we'll good luck with all that you do. Take care.